Spinal cord injuries and conditions and their definitions, deficits, and adaptations for para-alpine skiing. Spinal cord injuries consist of cervical-level spinal cord injuries, thoracic-level spinal cord injuries, and lumbar-level spinal cord injuries. Spinal cord injuries are either complete or incomplete, meaning the spinal cord is completely damaged or partially damaged. Conditions of the spine include spinal stenosis and spina bifida. The cervical spine consists of vertebrae C1 through C7. The deficits listed are specific to a complete injury. An incomplete injury could mean the deficit exists, could be partial, or could be non-existent. C1 injuries experience facial movement and sensation, reduced ability to speak and breathe, and loss of bowel and bladder function. C2 injuries experience facial movement and sensation, reduced ability to speak and breathe, loss of bowel and bladder function, and they can use a mouth stick to assist in tasks of daily living. C3 injuries experience facial movement and sensation, head and neck movement, loss of bowel and bladder function, and they can use a mouth stick to operate a wheelchair. C4 injuries experience facial movement and sensation, head and neck movement, loss of bowel and bladder function, the ability to operate a motorized wheelchair, and they may shrug their shoulders. C5 injuries experience face, head, neck, and shoulder control, loss of bowel and bladder function, and ability to flex elbows. C6 injuries experience face, head, neck, and shoulder control, loss of bowel and bladder function, diaphragm control, they have elbow flexion and wrist extension. C7 injuries experience face, head, neck, and shoulder control, loss of bowel and bladder function, diaphragm control, they have elbow flexion and extension, and they have wrist extension. Most individuals with a cervical-level spinal cord injury require assistance in completing activities of daily living and are unable to transfer themselves. The thoracic spine consists of vertebrae T1 through T12. The deficits listed are specific to a complete injury. An incomplete injury could mean the deficit exists, could be partial, or could be non-existent. T1 and T2 are injuries experience movement of the face, head, neck, shoulders, and diaphragm, loss of bowel and bladder function. They have elbow flexion and wrist extension. T3 through T8 injuries experience movement of face, head, neck, shoulders, and diaphragm, loss of bowel and bladder function, and ability to use upper extremities. T9 through T12 injuries experience movement of face, head, neck, shoulders, and diaphragm, loss of bowel and bladder function, and they have the ability to control upper extremities and the ability to control their upper torso. The lumbar spine consists of vertebrae L1 through L5. The deficits listed are specific to a complete injury. An incomplete injury could mean the deficit exists, could be partial, or could be non-existent. L1 through L5 injuries experience control of their upper body, diaphragm, and torso, loss of bowel and bladder function, and the potential to walk with an assistive device. This is a map of the dermatomes in the human body. This identifies which area of the body each section of the spinal cord provides sensation to. The ASIA impairment scale is used to identify the spinal cord injury as complete or incomplete. If the injury is complete, it is labeled as an ASIA A, meaning there is no motor or sensory function below the lesion. If the injury is incomplete, it could be classified as an ASIA B, C, D, or E. B means there is no motor below the lesion, but they have sensations. C means they have motor and sensory, but 50% of their muscles score less than a 3.3 out of 5 on the manual muscle test. D means they have motor and sensory, and 50% of muscles score higher than a 3 out of 5 on the manual muscle test. Finally, E means their motor and sensory function is normal below the lesion. Participants with spinal cord injuries and conditions frequently experience complications due to deficits and syndromes. These complications include pressure sores, spasticity, circulatory defects, and autonomic dysreflexia. Pressure sores occur in people with spinal cord injuries due to impaired motor control and sensation. Spasticity involves muscle overactivity due to a disruption in the communication between the brain and the spinal cord following a spinal cord injury. Circulatory deficits occur when the spine is injured because the brain loses ability to communicate with the cardiac nerves, causing a lack of blood flow in certain areas of the body. To avoid circulatory deficits, spasticity, and pressure sores, the participant must be adequately positioned in the sit ski. The participant must also be kept warm while skiing to support circulatory deficits. Autonomic dysreflexia usually occurs in people with damage to T6 or above. Dysregulation of the autonomic nervous system leads to an uncoordinated sympathetic response, causing sudden rise in blood pressure. This is due to a person's inability to feel stimuli like restrictive clothing, a full bladder, pressure areas, broken bones, and fecal impactions below the T6 level. Symptoms include sweating, confusion, headache, and high blood pressure. The participant and instructor should attempt to find the stimuli to remove it or seek medical attention immediately, as this is considered a medical emergency. Spina bifida is a condition that affects the spine due to a neural tube defect. The neural tube does not close correctly in utero, causing a section of the spinal cord to be exposed. There are 3 types of spina bifida: spina bifida occulta, meningocele, and myelomeningocele. Spina bifida occulta is nicknamed hidden spina bifida because the sac of fluids does not come through the opening of the neural tube, usually not causing a disability. Meningocele occurs when a sac of fluids comes through the opening in the neural tube, which can lead to muscle weakness and loss of bowel and bladder function. Myelomeningocele is the most severe type because the sac of fluid with the spinal nerves comes through the neural tube. This can cause loss of movement and/or function in lower extremities. Participants with spina bifida can use a biski, monoski, 4-track, ski bike, or slider depending on their ability level. Participants can stand ski if they are a low risk of injuring their spinal cord. Spinal stenosis occurs when the spaces in the spine narrow and pressure is put on the spinal cord and nerve roots. This is commonly found in the lumbar region of the spine. Numbness and tingling occur at the level of the spinal cord affected and below. This may cause a person to lose motor or sensory function. In more severe spinal stenosis cases, participants may present with a complete or incomplete spinal cord injury. Participants can stand ski, ski bike, or use the slider depending on the severity of the condition. It is important to take breaks and be cautious, as participants with spinal stenosis are at risk of worsening their condition. Adaptive equipment allows each participant to ski down the mountain as someone without a disability would. Starting in the top row from left to right, this is the adaptive equipment frequently used for participants with spinal cord injuries and conditions. So starting with a slider, this is like a walker with skis attached. A snow-go, similar to a ski bike, except you stand and hold onto the handles. A ski bike, the participant sits and can either put their feet on the pegs or on the ski blades. A bi-ski, which is a sit ski with 2 skis attached. The instructor can either seat assist this down the mountain or use tethers, or the participant can ski independently. A monoski, which is a sit ski with 1 ski attached, which is just more difficult. And then handheld outriggers, which are used for sit skiing and 3-tracking and 4-tracking when they're lengthened. Several assistive devices are used in combination with the adaptive equipment. When skiing with a participant with a spinal cord injury, proper positioning is crucial. Extra chest straps can be beneficial for someone who has a difficult time engaging their core to sit up straight. Active hands can be helpful for someone who has a difficult time with upper extremity and fine motor control. This can be used to attach a participant to the handles of a ski bike or outriggers. Foam is also helpful when fitting someone into a sit ski because a perfect fit is crucial to avoid injury or pressure sores. Adding foam to empty spaces can improve the participant's skiing ability and make them more comfortable. Participants with spinal cord injuries often use a catheter to empty their bladder due to incontinence. The catheter bag can be placed on the participant's lap in a sit ski underneath a blanket to avoid freezing. If the catheter bag or tube freezes, it is crucial to go inside and unfreeze it to allow urine to move through the tube. The participant will most likely have a preference for where they would like to keep their bag. There are numerous benefits when skiing for somebody with a spinal cord injury or condition. Skiing can encourage improved posture and mobility. Skiing can increase a sense of confidence and self-worth. And finally, skiing can improve social participation because many people with spinal cord injuries and conditions are isolated due to decreased mobility. Skiing with a spinal cord injury or condition can be considered dangerous due to the severity of the conditions and the sport being extreme. There is a risk of a complication occurring while skiing, a risk of increasing damage to the spinal cord when falling, and a risk of staff and the participants sustaining an injury from falling while using the adaptive equipment. The equipment used during lessons is extremely heavy and complex and can be dangerous if a complication occurs.